Hello, everyone, and welcome to today's OKA webinar. My name is Savita Baja, and I am the incoming president of the OKA, and I'm happy to be here to introduce our speaker for the day that's going to be presenting the efficacy of exercise and for preventing and treating obesity. Today we have here Jennifer Cook, PhD, is currently a professor at the School of Kinesiology and Health Science at York University. Dr. Cook has published over 130 peer-reviewed papers related to obesity, health, diet, and physical activity behaviors. Dr. Cook is an author for the Canadian Adult Obesity Clinical Practice Guidelines, and her expertise is in epidemiological and clinical human intervention approaches that facilitates collaborations across a number of disciplines. Currently, her laboratory is investigating the relationship between obesity and health through clinical human studies and epidemiological approaches. In particular, she is interested in the characterization the metabolically normal obesity phenotype and is currently working on factors that identify successful weight management in adult and pediatric populations. This work will help to clarify the most optimal weight management strategies for maintaining and improving health. So I'd like to welcome Jennifer here today with us. Throughout today's presentation, if you do have any questions, Jennifer has said that she is willing to answer them as we go along. Please use the Q&A box at the bottom of your screen to input your questions. And if we don't answer your questions throughout the presentation, there is some time reserved at the end to follow up on any additional questions. All right, without further ado, I'll hand it over to you to get started.
Thanks, Savita. I didn't realize you'd be reading my whole bio. I would have shortened it otherwise. Okay, so today I am tasked to talk about obesity, and I'm going to address some of the common myths that we have in exercise sciences. As a disclosure, I have 3 degrees in kinesiology and exercise physiology. I will speak a little bit to pharmacotherapy, and I want to tell you that I'm not paid by pharmaceutical companies. And the other thing is I do not have firsthand experience of what it's like to have obesity or have to engage in significant weight loss. So these are things to keep in mind when going through my talk, in that I'm really coming from a researcher perspective and someone who's involved in clinical weight management, but I don't have to necessarily deal with the day-to-day. So when we think about traditional obesity treatment guidelines, it typically says that we should start with lifestyle modifications, so dietary interventions or physical activity. And when that's not successful, then we move to the next layer in the pyramid, so pharmacotherapy. And then when pharmacotherapy is not successful, then we would address surgical options. And so today we will be focusing on the physical activity and how physical activity may theoretically and what we see in reality from intervention studies in terms of how it helps with obesity management and weight reductions. And so this is a systematic review that's looking at high intensity interval training versus moderate continuous interval training. So this would be your normal just running 30 minutes on a treadmill at a constant speed or pace versus the high interval where you have various intervals of high intensity followed by rest or lower intensity exercise. And the author suggests that both are associated with significant weight loss, which is fantastic. And in fact, there's no difference between high intensity interval training or the moderate continuous training. But when we take a look at the magnitude of weight loss that we see between the 2 interventions, we see it's about a 0.5 kilogram weight loss. And this is over 5 to 16 weeks. And so if we think about what our clients might want in terms of their weight loss goals, this might fall significantly short of what is desired versus what we actually see in exercise interventions. And this is actually not new. There's a meta-analysis that was published on the 25 years previous, and this was published in 1997. And even then, it was already suggested that exercise is not going to be associated with significant weight loss. Here, they suggest maybe closer to 3 kilograms. And if you engage in diet weight loss or a combined diet and exercise weight loss, you're going to get significantly more weight loss. And adding diet to exercise doesn't actually improve your weight loss that much. When we look at the clinical obesity guidelines that were published in 1998, again, we see that aerobic exercise results in modest weight loss of less than 2 kilograms. And so this is the weighted evidence that suggests that exercise in itself is not going to be associated with large amounts of weight loss or reductions in abdominal obesity as measured by waist circumference. Okay. And, this goes in contrast with some of the research that's suggesting that there is this linear relationship between how much exercise you do and how much weight loss you have. And so this is a study that was done by Ross and Jansen, basically looking at the energy expenditure in calories per week. And they basically show that the more exercise you do, the more weight loss you're going to expect to have. And you see a similar association with fat loss in blue. There is spread in this relationship, but you can see that the vast majority of studies are clustered down here. And this is an important point. This is where the physical activity guidelines are in this range of energy expenditure. If you suggest that someone goes and does 150 minutes of exercise per week, they are going to have more modest energy expenditure, and that translates into the modest weight loss that we see in the exercise interventions and the meta-analysis that I showed you in the previous study. If you want a comparison, diet interventions typically have a caloric deficit of 3,500 calories per week. And so if you're to compare diet versus physical activity, this is why diet interventions are almost always showing more weight loss than physical activity interventions. It's because of the calorie expenditure that is prescribed is far less than what the caloric restriction with diets. This is a study that has matched energy expenditure through exercise in green versus diet weight loss, so calorie restriction. And when you see that if you match the energy deficit, you see similar weight losses. And so there's a study in men and women showing the same type of result. And so is exercise associated with significant weight loss? And so here I mean statistically significant weight loss, and the answer is yes. But the absolute weight loss that we see is typically very small unless you're doing a large amount of exercise. And so the previous exercise study here that I was showing, these men and women were doing an hour of moderate to vigorous, closer to the vigorous end of activity per day. Okay, and so that's a significant amount of weight loss. Okay. So the next point I wanted to talk about is how much muscle you can gain with exercise and how many extra calories you might be burning if you did an exercise intervention that's associated with a lot of muscle gain. And so here I asked my best friend AI, how much muscle will I gain if I lift weights? And so here you can see I've highlighted the answer from Copilot, and they're suggesting 1 to 2 pounds of muscle per month during the first year of consistent training. Okay, and they do note that women have typically less weight muscle gain than men. Okay, and so when we take a look at cross-sectional studies looking at power lifters versus basketball players and bodybuilders, you can see that they have significantly more muscle than the non-athletes. So the non-athlete in this study, this is a study of male athletes, have about 40 kilograms of muscle as compared to 50, 55 versus almost 60 kilograms of muscle. So significantly more muscle you can hypothesize that you can gain if you engage in regular weightlifting. Okay, and if we go back to our Harris Benedict, we know that the heavier you are, the more calories you burn. And specifically, we know that skeletal muscle is a more metabolically active tissue. And so it burns more calories than you would with adipose tissue. Just a note, the residual mass, these would be your other organs like your heart, your liver, your kidneys. Those actually burn significantly more calories than your skeletal muscle, but you can't do anything really to make those bigger. So that's really not something that you can intervene on, but just something to know that those other internal organs are actually burning far more calories than your skeletal muscle when you're talking about resting metabolic rate. Okay, so if we take that 13 calories that you burn per kilogram muscle, and we go back to this table of the amount of muscle that we have in these different athletes, we can see that the bodybuilders are maybe burning close to 250. The bodybuilders maybe 120 calories extra due to the fact that they have more muscle. And so this seems like a pretty good area for intervention that would help you with your calorie management if you can just increase your muscle mass. However, when you take a look at longitudinal increases with the persistence exercise, you see far smaller numbers, okay? And so here, remember, we're talking about 25, 35, and 45% more muscle, whereas when we take a look at interventions, we're seeing closer to maybe the 10% range at most. And so significantly different numbers than what we see comparing elite athletes versus what we see in sedentary individuals adopting exercise interventions. And so if we go back and assume that 40 kilograms of muscle for that sedentary individual, and then we give them a 10% increase in muscle mass, then that means we're translating it to a 4 kilogram increase in muscle or 52 extra calories in your resting metabolic rate. And so that would be about half a Timbit. So not a whole lot. And this would be far less than the 120 to 240 that we see with cross-sectional research. Okay, so again, I think we need to be careful when we take a look at what evidence that we're using to inform our practice. When we take a look at longitudinal evidence, it's not nearly as supportive as the cross-sectional evidence. And so you have to remember that cross-sectional evidence has a lot of selection bias that's associated with it. And so really you need to look at what is the longitudinal interventions telling us is a reasonable gain. Okay, and there's more bad news because when we take a look at, who we're targeting, if we're targeting middle-aged adults with overweight and obesity, and we look at how much muscle gain that they have with persistence training, this is 0.35 kilograms of lean mass. And so again, if we're assuming that 13 kilograms per kg muscle, this translates to about 4.5 kcals. So again, not the magnitude that probably our clients would be seeking for weight management. Okay, so the other question we can ask is, does fit muscle burn more calories than unfit muscle? And so, in other words, we might not be increasing our muscle mass 45% like we see in the bodybuilders, but that doesn't mean that our muscle isn't actually burning more calories because it is more fit. And so this is a study that was done a while ago, and what they took a look at is basically how many calories the muscle burns at rest. And I just wanted to highlight the methods that they used: a ventilated hood for RMR, which is one of the gold standard methods, and underwater weighing for body comp. And at that time, that would have been the gold standard measured for body comp as well. And what they saw is that, again, aerobically trained individuals had about a 9% higher resting metabolic rate as compared to the untrained, and then the resistance trained had a 15% higher resting metabolic rate as compared to the untrained. And again, remember, there are differences in fat-free mass between these groups. So after they adjusted for the differences in muscle, we see that, in fact, it's reversed now. So those who are aerobic athletes actually had an 11% higher resting metabolic rate, and those who are resistance trained have a 5% higher resting metabolic rate. So again, suggesting that maybe it's not just the absolute muscle, but that every kilogram muscle also burns more calories. And so again, two avenues in which your muscle might be helping you managing your calories. Unfortunately, the evidence is not all supportive of this. This is another study that looked at bodybuilders versus control subjects, and actually they were a little less controlled because they allowed participants to exercise normally in the days preceding the test, and so any acute effects might still remain. And they actually saw no differences between the bodybuilders and the control subjects after you adjusted for lean mass. And so again, whether or not there is a more calories burned with fit muscle, we're not sure, but it might be quite modest, and it might be more apparent with aerobic exercise than resistance exercise. So the exercise, resistance exercise will help you improve your muscle, but maybe not as much the resting metabolic rate of that muscle. Whereas aerobic exercise, maybe you don't get that muscle gain, but it could help potentially with the resting metabolic rate. Okay, so if we put it all together, I know I apologize, this is kind of like math class. You have 45 kilograms of muscle starting, and then we do training, we can get an extra 4 kilograms. Again, that means 52 extra kilocals. If we assume that 10% increase in resting metabolic rate or in muscle activity, then that translates into 57 extra calories. And so altogether, we're talking a best case scenario of 110 calories. Okay? So again, if we're thinking about 500 calories per day as being the energy deficit that you're targeting, this isn't it isn't going to be the whole picture. It's not going. You're going to have to do more than that. Okay. So will resistance exercise help me gain muscle and burn calories? The answer is yes, but the absolute amount is small. At most, 110 calories. If you use the more conservative numbers, then we're talking about less than 10 kcals. So again, we're not sure. And the other issue is that there's more and more research that's suggesting that there is what's called a constrained physical activity. And so the amount of physical activity that you do is actually dictated by the genes that you have. And so this is a study looking at adherence to the exercise regimen. And what they showed is that the phenotype that you have is actually predicting your exercise adherence. And so depending on the genes that you have, you're more or less likely to drop out of that study or the exercise intervention. But what's important is that the genetic predictors of physical activity are not consistent between studies. And so one study might say it's gene A, but another study says it's gene B. And so there's a lot of disagreement in this area. Where you see a little bit more consistency is when you take a look at twin studies. And so this is a study looking at monozygotic, so identical twins. And what you see is over time, twin one is doing pretty much very close to the same physical activity level of twin two. If you look at dizygotic twins, especially of the opposite sex, what you're seeing is at a far less correlation. So more genetic variance, more variation in terms of the physical activity patterns that you see. And so again, suggesting that genes, even in twins that are reared separately, may have a strong influence in terms of the physical activity engaged by that individual. This is a cross-sectional study looking at 3 populations, Hasda hunter-gatherers in Africa versus your typical Western modern man, and then the subsistence farmers. And what they looked at was the total energy expenditure, and so the BMI. And so as expected, those of us that live in the modern world have a higher BMI than those who are the typical hunter-gatherer populations and the subsistence farmers. But when you take a look at the total energy expenditure, there's actually no significant difference between these 3 populations, suggesting that even though we don't necessarily have to run down or grow our food and engage in all of this physical labor, we actually don't have differences in our total energy expenditure despite our sedentary lives. And so part of that is due to our larger size and the fact that you take more calories just to move. But there is this suggestion that maybe that this total energy expenditure is programmed within our genes, which is why there is challenges with exercise interventions. And so this constrained physical activity means that as kinesiologists, you're trying to get individuals to be more active. But what happens is that they actually cut away physical activity through other periods of time. So if you think about, they might go for your 30-minute walk, but then they rest a little bit more through the other times. And so where they think that this is controlled is at the level of the brain, and I'll talk a little bit more about this later, in your hypothalamus. And so this is an area where you don't control. It's not something that's conscious. And so even in studies where they say don't change your physical activity through the rest of the day, individuals don't know that they're doing this, but it's captured in objective physical activity monitoring. Okay? And so here's another study that is basically taking a look at walking. And so they took a look at the exercise that was done on non-walking days during the intervention versus walking days. And so when they provided the intervention and had them walk, they actually did less activity through the rest of the day as compared to the days that they didn't have the intervention. And then and certainly less than before the intervention started, and then less than after the intervention was done. And so again, there seems to be this compensation that happens. So as kinesiologists, you get them to do more, but then they'll cut back through the rest of the day. And we're not exactly sure how we can get around this, particularly if it's programmed within your brain. And so this is the set point theory. And they discovered the process, which is a Glios process, which is a scarring in the hypothalamus. So think of it like a notch that goes, you're 100 pounds, 120, 150, 200, 300, and this is a one-way street. And so once you've attained that, your body will defend that point, that body weight, and not allow you to go down. And because it sees it as starvation, and so it sees it as a negative thing. And so part of the reason is if you increase your energy expenditure, you're losing weight, your body's going to try and defend that by down regulating your energy expenditures in other areas. And so you can combat that with your executive function, your willpower, right? So you can actively combat against things that your body naturally wants to do, because we know this is what's going to happen. But this takes willpower. We know that executive function is not something that you can activate 24/7. And you have to spread it out, not just on weight management, but all the other stressors you have on your life, right? Making sure that you're on time for this webinar so that you're not late. Going grocery shopping so that you have healthy options to eat, your normal job, family commitments, all of these things require executive function. Okay, willpower to do the right choice that's not natural to your body's physiology. Okay, and this is the struggle. And so although I showed you this dose response relationship with shorter term studies, what happens longer term is that likely your hypothalamus in your body is detecting this weight loss, detecting this elevated energy expenditure and saying, no, that's not what we want. And it's going to oppose it. And so when we take a look at longer term studies, there's actually no relationship between energy expenditure and then weight reduction. Okay, and here's a study that was taking a look at a longer term weight loss, and they prescribed progressively more and more exercise. And what we see is that the group that was prescribed more exercise actually lost less weight than the group that did a little bit less. And so again, this is suggesting that your body's physiology is going to combat your attempts at weight management through lifestyle and exercise. Yeah. And in fact, when you take a look at the percent that lost less than you expect, it increases with increasing exercise dose. And so that just means that there's more and more that we need to resist against, use that executive function to combat against your physiology, which sees this weight loss as a negative event. Okay. And we know that our body is very able to match caloric intake with physical activity through this study done in the 1950s. We've known this. And so this was a study looking at different types of occupational work that they categorized into sedentary, light, medium, heavy, and very heavy. And so remember, this is from the 50s. And so probably even their sedentary workers probably had to do a lot more occupational physical activity than most of us today. But what they see is that if you are forced to do a lot of labor, for example, through your occupation, your body will compensate by having a higher caloric intake. Where there is a dysregulation is in that sedentary jobs, where there is a increased caloric intake relative to their energy expenditure. And so if we think about our modern day society, probably most of us now are sitting in this sedentary area. So our appetite and physical activity are mismatched. So we're eating more and we're hungrier than we should because we're not active enough. Okay. So how do we, and so this begs the question, how do we create an environment that forces people who maybe are not naturally active to be more active, right? And so this is the question that we have yet to remain. And I guess that's really your job. Okay. The other issue that happens when you have exercise interventions is that there's body compositional changes and resting metabolic rate changes that also occur that make it more challenging because you're actually going to be burning less calories because there's less person, there's less fat-free mass. And so if you have diet only, or diet in combination with aerobic exercise or strength exercise, what we see is that weight loss is not just fat mass. You get fat-free mass loss as well. And this is true for any weight loss intervention. You will have fat-free mass loss. Okay, absolutely. Okay, as long as you get significant weight loss, part of that tissue loss is going to be fat-free mass. And if you lose fat-free mass, then you will also have negative changes on your resting metabolic rate. Okay, because there is less of that active metabolic tissue to burn calories. Okay. And so again, even with strength training, it does not negate the loss in fat-free mass, and it doesn't negate the loss in resting metabolic rate that you see if you have weight loss. Okay. And when you have significant weight loss, and so this is the biggest biggest loser study, where they had significant amount of weight loss. They studied the individuals afterwards, and they could see that over the 6 years after the show ended, almost all the individuals regained their weight, other than one. But what is very, very, very negative is that when you take a look at the resting metabolic rate, it's also going down. Despite the fact that they're regaining their weight, their resting metabolic rate is still lower than what you would expect. And in fact, their resting metabolic rate is about 500 calories lower than it should be at the 6-year mark out. Okay. And so again, when you try and engage in a lifestyle intervention, your body has dramatic ability to downregulate their resting metabolic rate far beyond what you'd expect given their changes in fat-free mass, because after 6 years, they actually regained their fat-free mass or increased their fat-free mass. But despite that, their resting metabolic rate's going down. So again, more challenges. What does this mean? That means that your client is going to have to exercise even more or diet even more just to maintain that neutral energy balance after their weight loss bout. Okay. And so your brain will defend your highest body weight, and your weight loss will decrease your muscle mass and your resting metabolic rate. And these decreases in resting metabolic rate may persist even after you've regained that weight. So again, making obesity management even more challenging over time. Okay. And so this is an important point that you have to remember, that energy expenditure is variable. Some of you are walking around, exercising a lot, eating a lot of calories, and you're like a monster truck, right? You just burn everything that you eat. You eat massive amounts of food, but you also burn massive amounts of calories. Some of you are going to be more like this Prius, right? So you eat very little, and you also burn very little. Some of you are in the middle. And what's interesting is, depending on the stressors and impacts, your exercise interventions, and changes over time, medications, you can actually change how efficient you are. Okay. And so this is part of the question is, where are you? And if you are this Prius, it's going to be tougher for you than the person that's the monster truck. It's probably never going to go from the Prius all the way to the monster truck, but the monster truck may become that Prius because our body and our brain wants to defend against weight loss. Okay. Another issue that's going to happen after you lose weight that's going to make it even more challenging for you to maintain that weight loss is that you actually burn less calories to do the same work. And so this is a study that looks at the calories that you burned during treadmill walking. And so in the blue is those that engaged in weight loss, and the red are those that did not lose weight. And so you can see that they're burning less calories. So they're becoming more efficient at the same walking because they've lost weight. And this is even after adjusting for differences in body size. Okay. This is a cycling exercise, and they show a similar observation. After the weight loss, individuals are burning less calories to generate the same wattage on a bike. And what they did in this study is they actually added physical weights back to the leg to compensate for the fact that individuals are now smaller now after the weight loss intervention. And despite that, they're still seeing this trend for burning less calories. Okay. So again, remember that if your client is doing the same exercise intervention over time and they've lost weight, likely they are burning less calories over time. Their body is going to become more efficient to do that same work. Okay. So when we take a look at, individuals that have lost weight, and so this is 30 pounds or more, and they've kept it off for more than a year, what are they doing? What we see is that their caloric consumption, this is typically mainly middle-aged women, is about 1,400 calories per day. They are doing about 30 to 60 minutes of walking most days of the week. And so when we take a look at, as a comparison, they're eating far less than what your typical individual would eat. And they're doing far more exercise than what your typical individual is doing. And this is for the rest of your life. And when you take a look at this cohort of, very unique individuals, they're actually gaining weight at the same rate as the general population. So that about half a pound to a pound per year weight loss that we see in the general population. Okay. When we take a look at individuals that studies that have looked at maintainers versus those that have regained weights after a weight loss intervention, they show an even bleaker picture. In red or pink, this is the bouts of physical activity done by individuals who maintain their weight loss. And what you see is that this is an upward trend. So after you lose weight, if you want to maintain your weight loss, you need to increase the amount of physical activity you do over time. Those individuals that kept the amount of physical activity they did constant regained weight. And so again, speaking to if you want to keep your weight loss, say 50 pounds, you actually need to do more over time just to stay at that 50-pound weight loss. You're not going to get more weight loss. You need to do more just to keep the weight that you've lost. Okay. When we take a look at the other side of the equation, eating efficacy, you're seeing that, and dietary restraint, you're seeing that they need to have more and more restraint over time. And this is true for both the regainers and the maintainers. And so what this means is that they're using more willpower, more executive function over time to make sure that they are eating right, eating the right type of things to maintain their weight loss. And again, remember, these individuals are not losing more weight. They're just maintaining their weight loss. And so the question is, this is a 24-month study. If we were to continue this for, again, the rest of your life, how much higher can this dietary restraint bar go? How much higher can the exercise bouts go just to maintain this weight loss over time? Okay. And so summary point number 4, weight loss will decrease your energy expenditure. So again, you're increasing your efficiency, you're decreasing your body size, so you're going to decrease your resting metabolic rate. All of these factors are going to make it so you might need to do even more exercise just to maintain your weight loss over time. And I know I'm showing a very depressing picture, but this is what the science is telling us. And this is why so many people are struggling with lifestyle weight loss. And this is why individuals creep back up, because they're fighting against their hypothalamus, their natural physiology. Okay. And so I'm sure many of you right now are thinking about that one client that you've had, the success story. And so I asked my other best friend, Google, show me some exercise weight loss testimonial examples. And the internet is littered with individuals who have gone from various sizes to smaller with exercise and have kept it off for X number of time. And, some of these are probably fraudulent, but I firmly believe that some of these are true. And the reason is that there is a lot of variability in individualized responses that are hidden in science that we don't normally talk about. So everything that I've shown you today are average group responses. Within that average group response, you're going to get people that do far better than average in terms of weight loss or any other variable that you wanted to put. And there's going to be individuals that do worse, right? And so you're going to have individuals that engage in exercise, supervised exercise interventions, that eat the way that they're supposed to eat and gain weight. There are just those individuals that are documented in every weight loss study I've ever done. There are individuals that just don't behave and don't respond in the way that we expect. And we can always explain it with they were not compliant. They ate more. They didn't do the exercise that we told them to do. Something happened that is their fault. They're lying. But I would also suggest that maybe they have an extremely strong set point and very sensitive hypothalamus that is compensating for all of their good choices and not allowing them to lose weight. That is the other possibility that we need to be sensitive of. Okay? Just like individuals can exercise, and some will be compensating with wanting to eat more. And they'll be very sensitive to that. And you have clients that tell you they are so hungry when they engage in exercise. If I do more exercise, I definitely compensate by eating more. And there are others that are going to be less sensitive to those, but they are fewer. And so again, remember that for some individuals, they are really, really going to be fighting against their physiology. And we shouldn't take that one unicorn and say that is the marker that we are going to judge everybody by. Okay? Because on average, it is a very challenging and bleak picture, is what the science currently tells us. Okay, so again, those individuals coming back to the weight registry that have lost 30 pounds and kept it off for a year or more, what we see is that these individuals actually have no reduction in resting metabolic rate. So I told you that many intervention studies are showing this reduction in RMR, but people who are able to successfully lose weight and keep it off, they don't have that. So again, are they typical of that normal individual that's trying to lose weight? Maybe not. And so you can't really compare successful people with the people who are with everybody else, because again, there might be a selection. These individuals might be genetically, I guess, quote unquote, blessed that their body is actually allowing them to lose weight and they're not fighting against it because their set point hasn't happened. They didn't have the glios happen in their hypothalamus yet, so they aren't defending that higher body weight. They're allowed to come back down. In reality, the percentage varies. The highest percentage I've found is suggests that 95% of individuals will not maintain a reduced weight loss long term, and this study went out to 5 years. And so most studies that have higher numbers use a shorter period of time, and it's because that weight gain is not complete. But most studies would suggest that individuals struggle, and many studies suggest that the weight loss maintenance phase is actually harder than the initial weight loss phase. And so keep that in the back of your minds when individuals hit a plateau, they're struggling, they're regaining their weight. That's actually normal. That is a normal physiological response that we're trying to fight against. Okay, and so just a reminder that your brain sees, for most people, weight loss is a negative thing that needs to be corrected. And so the physiological responses that we're seeing is our body trying to defend ourselves from starving to death. Even if your client weighs 300 pounds, your body and your brain sees it in the same way. You're losing weight. That is something that needs to be corrected. And so we need to correct that. So in the short term, your client can use executive function to try and combat that. But this is not something that's 24/7, and it's not going to be able to be sustained without significant effort long term. Okay. And so are there people who can lose lots of weight and not have increases in appetite, decreases in resting metabolic rate, and increases in exercise efficiency? Yes, there are unicorns out there. Okay. But they are likely the minority. And so, I think that as kinesiologists, we've known for decades that individuals struggle to lose significant amounts of weight with exercise only, unless you add diet in there. And we know that with diet and exercise weight loss, individuals tend to regain weight. And so is it time to recalibrate our expectations for exercise weight loss? And what individuals are coming to us for. And so here is my pharmacotherapy slide. And so we have a lot of new drugs, particularly type 2 diabetes drugs that are on the market that are associated with weight losses that are actually far more than what we typically see with diet and exercise. So again, remember exercise, we're seeing less than 2 kilograms, diet, maybe that 5 to 10%. Diet and exercise still in that 5 to 10% range. Bariatric surgery gives you about 30%. We are now approaching medications that are coming close to bariatric surgery. Okay? But even with the improvements, weight loss goals are still far, far higher. Individuals taking these medications, most of them, if they're starting in class 2, class 3 obesity, will not attain a normal weight. We don't have interventions that are that effective yet. And this is why the updated obesity guidelines are suggesting that we do everything right off the bat. We do medical nutrition therapy or, addressing diet, physical activity, psychological interventions. I'm not going to talk about that today, but that is a big part of obesity intervention, pharmacotherapy, bariatric surgery. And so again, we decide all of these will be done immediately, but then the question is, why are we not adding this immediately? And so depending on the patient needs, the patient's wants, and their qualifications, we can give them pharmacotherapy and bariatric surgery right away. We don't need to wait for diet and exercise to fail because we know in the vast majority of individuals, it will. Okay. So my take-home message is exercise associated with health benefits. I didn't talk about that, but the answer is yes, it clearly is. I'm not saying that you don't have a job, you do. But I think that we need to be honest in terms of what exercise can do. It can make people significantly healthier, but it's not associated with significant weight loss. And that is something I think that, even if you increase your resting metabolic rate, even if you increase your amount of muscle, the limits of exercise, particularly for individuals who are struggling with obesity, is just not as large as I think that we want it to be. Okay. And is exercise beneficial for weight loss maintenance? And the answer is it can be, but you have to do a lot and you might have to do continually more and more over time. And so this is why, I think that as kinesiologists, we tend to be very negative against medications. But given the science, just like diabetes medications or hypertension medications, I think that this is something that we need to just accept as something that individuals need because obesity is a chronic disease. And so again, I'm going to challenge you as kinesiologists, given the limits of lifestyle intervention, should we as kinesiologists ethically only advocate lifestyle weight management for obesity? Okay. Or should we start treating obesity like other chronic diseases? Okay. And so thank you. I'm going to open the floor for questions.
Thank you so much for that presentation. If anybody has questions at this time, feel free to put it in the Q&A box at the bottom of our screen, and we can get started on answering some questions.
I'm sorry if I'm depressing you all, because I know this is your livelihood. And I do tell my students who are, personal trainers and things like that, it's not that like, how do you balance the trainers that are saying, hey, if you train with me, I can help you lose 100 pounds versus what is reality. And I think this is a question that you need to ask yourself in your ethos. But, the science of it, I don't think that we should continue to sell lies. I think that we should think about, exercise and all its good things, but not make people feel bad when they're doing exactly what their physiology programs them to do. Did we lose everybody?
give everyone a moment to answer. But any questions?
Okay.
Oh, we got a thumbs up, so we haven't lost everyone. I think they're great questions to ask, and I think it's amazing to just be able to look at these different factors that we have that science is telling us.
Yeah.
Great
So
question.
yeah, weight loss meds. There have actually been many studies that have taken a look at weight loss meds and what happens when you stop. And so basically what you see is that, your weight comes down, you stop taking the medication, the weight goes back up, then they restart the medication, the weight comes back down. And they kind of keep doing this hill thing. And then eventually, if you just keep taking the medication forever, you kind of reach that plateau, just like exercise and lifestyle. Eventually, your body's going to have that new homeostasis, that new plateau. And depending on that medication, that where that plateau happens differs. Okay, but yeah, it's not like an antibiotic where you clear the infection and then it's gone. You can't take the weight loss medication, cure your obesity, and then stop taking it. It's a chronic disease, which means you have to keep taking it, which means you have to keep paying for it because most private health insurance don't pay for it. And so it's very, very expensive. Okay, so I don't think that we're setting a risk in prescribing exercise. I think that what the issue is expecting that exercise is going to do something it can't. Okay. And so, for example, my cell phone is very, very useful to me. That's my family, right? But if I expect that this would be a good hammer, that's just not a rational expectation. Exercise is going to be great for improving your aerobic fitness, your independence, your flexibility. You know all of the things that exercise is very good at. Acute exercise is great for improving your insulin sensitivity and your blood pressure. Okay, but that doesn't replace the medications, right? And I think that obesity, we're at that same point now where that we need to recognize that exercise is great. It's something that we should all do, right? So that we don't get that mismatch and we're eating more than we should. But expecting that we should do hours and hours of exercise to keep off your weight loss is probably not a reasonable expectation long term. Okay. And it's probably not healthy either if you really think about it, right? So if you think about the people that are, exercise addicts, like that's another extreme. But I think that there's a genetic susceptibility to that. People have actually done research in that. Can we get people addicted to exercise? And the answer is so far, it's a very challenging thing that you can't do. Um, does a 5 to 10 pound weight loss mean that they've altered their resting metabolic rate? And the answer is it depends, right? So again, how sensitive is your hypothalamus? And this is again dictated by your genes, your brain physiology. Some people, yes, and some people, no, right? So we know people who have lost 50 pounds and kept it off, and it's amazing for them. I'm very happy for them, but they're amongst the minority. Okay. And so again, we can't compare everyone versus the unicorns, the people that are very successful and are just genetic freaks, actually. We have to compare them versus the average person, what is reasonable. So the smaller your weight loss, the less likely your body is going to respond in a negative manner by decreasing your resting metabolic rate. If you know The Biggest Loser, is actually a very traumatic experience, actually, because they exercise like all day, they eat almost nothing, they lose significant amounts of weight, but what you see after the show is over, they all rebound in their weight and they're actually heavier than when they started the show. And there's some scientists that believe that your body will react in this as like a trauma. And what does your body do in response to a trauma? They try and protect you against future trauma. For obesity and weight loss, what is that? Decrease your resting metabolic rate, make it so that you store adipose tissue easier, right? And so this explains potentially why they have that accelerated weight gain and why they're far heavier than before they started the show, right? It's a survival mechanism. Okay. Yes, so fat cells only shrink, they never go away. There are situations where they do die, but typically those are associated with negative health consequences. So if you think about your subcutaneous adipose tissue, so this is the fat cells that are under your skin, this is, your spare tire that you can pinch. Your subcutaneous adipose tissue is actually a good thing. because what it does, it sucks the fatty acids from out of your bloodstream so that you don't have high triglycerides, you don't have high cholesterol. And what happens is that when it gets full, like in a situation where you have obesity and it can't take up all the extra calories, that's when it causes problems. And so there's actually a class of type 2 diabetes medications that actually allow your subcutaneous to actually get bigger much faster. And what happens is that you get healthier, and they give super high doses to these mice and they get so fat they can't walk anymore, but they are perfectly non-diabetic and healthy in from a physiological standpoint, right? And so don't think about fat cells as a bad thing. They're actually doing their job in terms of clearing your blood to keep you healthy and not developing atherosclerosis. It's when it gets full and can't take any more that causes these problems. So who qualifies for these medications? So in Canada, doctors can prescribe on for the use, and then they can prescribe off-label. So all of you have heard of Ozempic. This is a type 2 diabetes medication. It's not an obesity weight loss medication. The Wegovy is actually the weight loss equivalent, but it's far more expensive than Ozempic. If you ask your doctor for Ozempic, regardless of whether or not you have type 2 diabetes, your doctor can prescribe it to you. And actually, there's a study that suggests that 50% of people taking Ozempic right now don't have diabetes. Okay, but almost no one takes Wegovy because it's so expensive. Okay. How do we engage with other practitioners to address individual needs? Okay, doctors are busy, dietitians are not particularly well networked in my experience. Okay, so this is always a challenge. So the field of obesity, there's a lot of myth, stigma, and beliefs that, I have people take my 4th-year class where I basically talk 12 weeks, a 3-credit course on this, and they still don't believe me at the end. In terms of the challenges of obesity management. So I think that, part of it is that we need to be a different kind of kinesiologist. We need to, understand people's struggle. And so when individuals exercise and they don't lose weight, we empathize with that situation. It's great that you're doing this. You are going to get health benefits from this. You're going to get fitter. You're maintaining your functionality, but your body has chosen to protect your weight. And that's why you're not seeing the weight loss. It's not that you're doing something wrong. This is the way that your body works, and this is your physiology. And learning to love your body in the way that it is something I think that we need to, start embracing a bit more, because clearly a lot of us are programmed to be different sizes, and some of us are programmed to be much, much larger than others. Yeah, but all of the healthcare professionals, they are not well versed in this. So plug for Obesity Canada, join. We have a conference every year that we talk about this, and medications, surgeries, lifestyle interventions, sleep, and stress. Yeah, so I would love to see you there. Somatotypes and how they would influence weight loss or recommendations for certain types. So somatotypes, I don't think it really matters in terms of what your somatotype is. If you have more of that apple shape or the visceral fat, there's evidence to suggest that you're probably going to be able to lose weight a little bit easier than the individuals who are pear-shaped. That partly is due to receptor sensitivity in your fat cells. But regardless of whether or not you started as that apple shape or started as the pear shape, the same trend remains. Like, how do you stay down there? Then most people will come back up. Okay, so remember all the factors that led to their weight gain in the first place are probably still in their life. And so until we can change society that makes it less obesogenic, those individuals who are susceptible will continue to struggle. So how do you get them out, right? So why is it that individuals can survive at The Biggest Loser by eating very, very little and exercising a lot? It's because of the environment that they're in. They don't work at their job. There's no family stress. Their job is to eat less, eat nothing, because there is nothing to eat, and exercise all day, right? But that's not the real world. And so really we have to find this balance of how much exercise is healthy and what is the what is my weight? And likely the weight that you have now is the weight that you should just try and stay at and try not to go gain more. Address the things in your life that are promoting that weight gain. But most of your clients have tried, they've rebounded. That means that their physiology is just not going to let them. And so I think that our efforts are probably better spent at trying to deal with the other lifestyle habits that we can address that make us healthier, as opposed to trying to get something that you might not be able to do because your physiology is just not programmed to do that. Yeah, so health benefits. This is going to be a hard sell, right? Because, our society is biased against people with obesity. And so everyone that comes to the Wharton Clinic that I work with is saying that they're coming there for health benefits. But if you dig a little deeper, there's always that aesthetic aspect. There's always the, issue of being judged and your self-image. If we are, truly looking at health benefits, depending on the metabolic variable that you're talking about or the mental health variable you're talking about, they require different amounts of physical activity. And so this is a totally different talk. But for example, if you're looking at hypertension, you can use very modest amounts. Okay, so you don't have to do vigorous activity. You can do light walking, but you got to do it twice a day. If you are diabetes and you want to improve your insulin sensitivity, then you have to do a little bit more work for a little bit longer, but you can do it every other day, right? And so this is where we have to, take a look at the physiology of the metabolic risk factor and then match it with our clients' needs so that we give them that type of exercise intervention that best suits that. Just like a medication, you'd want the proper medication, the proper dose. I think that, you just have to target the physiology of the exercise to give them the health benefit that they want. Is there anything being done on the resetting of the hypothalamus? Yeah, there's a whole field of research right now, basically trying to, I know that there's researchers working on a vaccine. So once you've attained your adult weight, they give you a vaccine. So the concept is you go to a cruise, they give you that vaccine, it protects you from the gliose process so that you can gain weight on the on the cruise and then lose the weight after without it resetting at that higher point, or, basically giving it to you so that you don't have to worry about it resetting at 300 pounds and then you can never come back down again. This is still, someone's dream. It's not my research area, but there's definitely scientists working on that. What's interesting is that bariatric surgery, for reasons unknown, seems to reset that hypothalamus weight. And so individuals will lose weight, and then they're not hungry and they're happy at that new set point. And so that's one of the reasons why bariatric surgery is so good. Genes, yeah, predisposed families, do they start and maintain persistent exercise from a young age? So if we look at obesity risk factors, that tracks very well for genes. If we take a look at exercise, that doesn't track as well. But it tends to be that, lifestyle clusters together. So individuals that are a little bit more active also eat better. And so we're not really sure if that's just and they tend to also be more educated, higher economic status. So remember that exercise and eating healthy are all things that require money and time and effort. And so if you are affluent, you're more likely to be able to even think about doing those things. If you have 3 jobs, a single parent, diet and exercise is probably not even going to come to the front of the mind. It's just not a possibility because it requires too much effort and executive function.
Seems like we'll have time for one more question, and then we'll try to follow up otherwise on the remaining questions that we do have in the chat here.
Okay. Yeah. Okay. So I'm going to go for the last question in terms of, what are you going to do to try and, promote this mismatch of appetite versus physical activity. And so the answer is, I think that we need to promote people to be more active. Absolutely. Yes. And so once, and how much is that? It gets to the point where, one, you can manage and fit it in your lifestyle without increasing your stress. And then once you see that you're increasing your physical activity and your appetite is increasing beyond that, then it's probably telling you that you've already hit that sweet spot. So you don't need to do more. You can do more, right? It's going to give you other health benefits, but not necessarily obesity related benefits. Okay, so that would be I guess, my final answer.
Amazing. Thank you so much for all those answers to those questions. I do see that we have more in the Q&A box. So what we'll do is we'll try to take them and have Dr. Cook take a look at them at another time and try to provide some responses if she doesn't mind for that. But I'd like to thank everyone today for your participation. And most of all, thank you, Dr. Cook, for providing such great information for everyone. I think there's lots more questions to come and maybe a part two as we go along with all these things that we need to continue to learn and continuing our own education. So thank you for attending today, and thank you again, Dr. Cook.
Thanks for having me. Take care.
Have a good night, everyone.